Dear doctor, I'm a lady aged 23 and I have 2 kids who are 3 and 1. I used Jadel after my first baby and people said if I do not menstruate, I will have cancer. That is when I had it removed and had my second baby. After the second baby, I have been using pills. She is 1 year old and I'm pregnant again. Do pills really work? And if I'm to go back to using Jadel, is it a problem when I do not menstruate?
Firstly, we want to empower our women to have a choice, to decide the size of their family. If they want to have 5 children, if they want to have 2 children, they should be able to have some form of control. They should also be able to control when they want to have a child, the kind of spacing that they want between their children. And family planning helps them to be able to control the family like that. We also have a category of patients who have some medical conditions like heart disease, or we have lung disease, and a lot of other diseases where we say to them, okay, if you fall pregnant, in the next pregnancy, you might have challenges, including even the risk of dying because of that pregnancy. So for those patients, to avoid or to stop them from falling pregnant, that is where family planning comes in. In some cases, the patient will not necessarily die from a pregnancy, but you are looking at the importance of saying, okay, can we stabilize their condition? Can we improve their disease? Can we make their disease better so that they are able to go through the pregnancy without any complications? So the family planning there comes in to say, how can we time the pregnancy? How can we delay the pregnancy so that the doctors and the nurses have time to stabilize their conditions? You also look at some conditions, for example, like epilepsy, diabetes mellitus, where we are saying, okay, how can we rationalize their treatment? How can we reduce the doses that they're taking or alter the drugs such that we can give them or control their condition using drugs that are acceptable in pregnancy, that are not harmful to an unborn baby. So family planning comes in to sort of delay a pregnancy in those kinds of situations, so that we optimize the condition of the woman, we can optimize the treatment, rationalize the treatment before she falls pregnant. So there's also the element of what we call the unmet need for contraception, where we are saying women who are not intending to fall pregnant, they are having sexual intercourse, but end up falling pregnant anyway, or end up failing to access the means to stop them from falling pregnant. This is a parameter that the WHO looks at. This is a parameter that the Ministry of Health also looks at. It is related to the number of unwanted pregnancies that we usually see in our hospital, and the number of unwanted pregnancies is directly related also to what we call the maternal mortality, the women that die from pregnancy-related causes. So you find that some of these women who have unmet need for contraception end up having unwanted pregnancies, and some of them will end up resorting to unsafe methods of terminating those pregnancies. Bilateral tubal ligation is a method of family planning which is meant for those patients that are a bit mature. Ordinarily, we would want to offer it in a patient who is above the age of 30, because if you offer bilateral tubal ligation to a patient who is below the age of 30, it has been shown that the rate of regret is very high. Someone who is above the age of 30 and has completed their family, they don't think that they would want to have a child in the future. So it's a permanent method of family planning. What are we doing with bilateral tubal ligation? We are basically cutting off the fallopian tubes. Cutting off the fallopian tubes, then we tie. Vazhinji vanoti kusungwa kwema tubes. Usually we do it concurrently with cesarean section. So at the time of cesarean section, after removing the baby, we then tie the tubes. But we can also do it even in a woman who is non-pregnant, completely divorced from a cesarean section. How does this thing work? Remember, the egg, in the process of conception, the egg is released from the ovaries here, and the egg in a woman is picked up by these fallopian tubes. The egg is picked up, and then it meets the sperm somewhere here in a place, in a part of the fallopian tube that we call the ampulla. And then the fertilized egg, over a period of 6 days, moves to the inside of the womb, where implantation happens, and the baby then goes on to develop within the endometrium, the inside of the womb. So what we are doing with bilateral tubal ligation, we are cutting off these tubes and tying them so that we establish a discontinuation of the fallopian tube. And that discontinuation gives us a situation where the egg is unable to meet the sperm. Even the sperm, when it comes from this side, it is unable to meet the egg. And that is how contraception is effected. The advantage of bilateral tubal ligation, number one, is that it is permanent. So once we do it, the patient does not need to look for any other method of family planning for life. So it's permanent, and that can be an advantage. It's also advantageous in the sense that the patient does not need to take those hormones, which may not be good for some patients with some medical conditions like diabetes, like heart disease. So it's good in that sense. But there are some disadvantages. Disadvantage number one, the permanency that I talked about can also be a disadvantage. If there are changes in social circumstances, then the patient might end up regretting why they ever tied their tube. Let's say, for example, somebody has got 3 children or 4 children, you tie their tubes, and there's an accident at home, and they lose 2 of their children. They might want to replace those 2 children, and if we tie their tubes, it becomes very, very, very difficult. Let's say also if there is a change of partner, somebody is married, they have 4 children, and then they go on to divorce, and the woman gets another partner, and the new partner wants his own children to solidify the union. It's very difficult now. The woman will end up regretting why they tied their tubes. The other disadvantage with bilateral tubal ligation is that it actually falls under major abdominal operations. So we actually get into the patient's abdomen, identify the uterus, identify the tubes, and we actually get to tie the tubes. And there are problems associated with that. So we are looking at the risks of putting the patient to sleep so that you are able to do that operation. There are what we call anesthetic risks, the risks that are associated with the process of putting that patient to sleep. The patient can aspirate, the patient can react to those drugs that we give when we put them to sleep. There is also what we call surgical risks, which means in the process of cutting the patient's abdomen, there are a lot of things that can go wrong. The patient can bleed. The operation can become infected after post-operatively. There's also risk of damage to other organs that are close to the uterus, the bowel, the bladder. Those organs can actually be be damaged as we are operating. I also want to highlight that because of improvements in medicine and surgery, we now have these bilateral tubal ligation being done with what we call minimally invasive surgery with laparoscopy. So that sort of minimizes the risks that I was talking about. There are two types of these tablets that are used for family planning. We've got what is popularly known as the control pill. Now, the control pill is, you easily recognize it because it's got 3 lines of white tablets. So that's 21 tablets, 3 lines. And then there's also this placebo, which is the brown tablet, 1 line of brown tablet. That is the control pill. The control pill has got 2 drugs. It's got an estrogen, and it also has what we call a progesterone. How it works? It works by inhibiting ovulation. It inhibits the production of or the release of an egg from the ovary. That's number 1. It also works by what we call reducing endometrial receptivity. So what do we mean by endometrial receptivity? We mean when a woman has ovulated, the egg is fertilized, it meets the sperm. 6 days later, it wants to come and implant in this inner lining of the womb. How is this inner lining of the womb ready to accept that fertilized egg? Think of it as you're preparing your seed bed. You want to sow your seeds so that you produce seedlings. You have to make the seed bed ready to accept your seed. It's more or less the same thing that happens in the endometrium in preparation for potential implantation of a fertilized egg. So the progesterone in the control pills helps to reduce the receptivity of the endometrium to the fertilized egg. The progesterone component also makes the cervical mucus that is produced by the womb. It makes it very thick, and it makes it very difficult for the sperm to penetrate into the womb. So those are the 3 mechanisms by which the control pill works. The thing about the control pill is that number 1, you have to take this every day, which really can be a disadvantage because the woman has to remember every day. If she forgets, she is at risk of falling pregnant. The issue also with the control pill is that it is not ideal for women that are breastfeeding, because it tends to reduce the quantity and the quality of the breast milk that is produced. So this is not recommended for women that are breastfeeding. The good thing about the control pill is that it has the benefits that have nothing to do with contraception. For example, if in a woman who has period pain, this tends to reduce period pain. In a woman who has heavy bleeding or irregular periods, the control pill helps to regularize the periods. It also helps to reduce the flow, the blood loss during menstrual period. And in those women that have issues like acne, so this tends to reduce the severity of acne. But you have to remember that the estrogen component in the control pill can be problematic in certain groups of patients. Those patients that have got migraine, those patients that have got severe hypertension, where the BP is very high, women that are diabetic, women that are at a risk of forming blood clots within their blood vessels. This may not be okay for them. In a woman who has had a stroke before, this is not recommended. The thing to do is, if you vomit within 30 minutes of taking the control pill, then you might want to take another dose, because by that time probably the tablet was still in the stomach, and you would have vomited it with the food that you would have taken. It is a problem in patients that are having diarrhea. You don't know now. There is this issue of what we call the gastric transit time, which means how much time does it take for the food that you swallow to come out at the other end. So in patients that have got diarrhea, that transit time is reduced, which means the tablets are going to run through your intestines, and they may not be absorbed as much. So this can be a problem in patients that are having diarrhea, patients that are vomiting. The other special group of patients is there are some drugs that can actually reduce the effectiveness of these tablets. So we are looking at drugs like a patient who is on TB treatment and is also taking the combined oral contraceptive or the control pill. The rifampicin in the TB drugs will actually reduce the effectiveness of your control pill. If a patient is epileptic, and is taking those drugs, phenobarbital and all that, to control the epilepsy, those drugs will increase the rate at which the body or the liver eliminates this drug from the body. So that reduces the effectiveness of the control pill. So you want to be very careful if you are epileptic and you're on treatment, if you are taking TB drugs, and even some ARVs. You have to discuss with your doctor. If you are taking ARVs, are those ARVs not going to reduce the effectiveness of the control pill? Just discuss with your doctor. They will be able to advise you. In medical terms, we call it the POP, progesterone only pill. So this is typically used by women that are also breastfeeding. Why is that so? Its mechanism of action is also complemented by breastfeeding. Remember, the very act of breastfeeding suppresses ovulation. And it can be used also as a method of family planning. We call it the lactational amenorrhea period. If you notice, most women that are breastfeeding, they won't be having periods. If they are breastfeeding consistently, they won't be having periods. Why? Because the act of breastfeeding inhibits ovulation and then provides some form of contraceptive cover. If a woman is breastfeeding, this progesterone only pill or the secure, it sort of helps, it works hand in glove with breastfeeding to provide effective contraceptive cover. The fact that it's a progesterone only means it's not going to really impact on the quality of the milk that is produced. It's not going to reduce the quantity of the breast milk that the woman is producing. Because there's only one drug only, the range of patients that are eligible for secure is wider than the control pill. So there are so many limitations with the control pill, but with secure it's more relaxed. Even some patients with some medical conditions can still take this. So you need to discuss with your doctor, and they will advise you whether it's still safe to take the POP if you've got some medical conditions. The thing now with the secure is that you have to take it every day, and not only do you have to take it every day, you have to take it at the same time and every day. So if it's 8 o'clock, it has to be 8 o'clock, or at least within 3 hours of that particular time. If you take it, say, at 10 today, and then tomorrow you take at 2 p.m., which is maybe 4 hours later, you are at risk of falling pregnant. The issues that we talked about of vomiting, diarrhea, and things like epilepsy and the drugs to control epilepsy also apply when it comes to secure. So those patients that have got those conditions are also at risk of reduced effectiveness of the secure tablet. If you are using the better methods, the condoms, and there's the male condom and the female condom. If you are using those, then you get you kill two birds with one stone. You prevent sexually transmitted infections like HIV, gonorrhea, syphilis, and you also get contraceptive cover. But the problem with condoms is that they tend to interfere with the sexual act. People are making love, and then at some point they have to stop and remember to put on the condom and to put it on correctly, which can be a problem. And then you also have to remember to carry them around everywhere, which may not always be possible. And you have to carry enough numbers of condoms, so for the amount of sex that you want to have, which can be a problem. They are also prone to breakages, particularly if they are not worn correctly. They are prone to breakages. They are prone to spillage, which can be a problem. And it also depends how you store them. If you store them in a very hot environment, and they are prone to breakages, and they can also be prone to being pricked by sharp objects like needles and all that, and that can be a problem. Always check the expiry date so that you make sure that you are using condoms that are still that have not expired. But the beauty of condoms, in addition to preventing sexually transmitted infections, is that you are not going to take any hormones. Two methods of family planning that tend to cause what you call amenorrhea, which means the woman might stop having periods. For example, the Depo-Provera, about 50% of women that are taking Depo-Provera will end up not having their periods. That is not a problem. Some women that are on the implants, the implanones, the Jadels, even non-plant previously, they would not, they don't go on periods. Some of the women, they don't go on periods. That is not a problem. For starters, if a woman is not having periods in this situation, it means the lining of the inside lining of the womb is not being prepared for that particular period. So it's not really a problem. And in any case, part of the methods of treating early signs of cancer inside the womb, which we call endometrial cancer, we use progesterones to actually suppress endometrial cancer. So if a woman is not having periods, and we can explain it in terms of the contraception that they're using, either the depo or the Jadel, it's not a problem. It doesn't affect their periods, it doesn't affect their fertility, and it does not have any risk of cancer. However, if a woman is not having periods because of other reasons apart from contraception, then you want to go to your doctor. They will evaluate you and they'll tell you if it is safe for you not to continue not having periods. We've spoken about a number of methods of family planning. Let me hasten to say that there is no method of family planning which is 100% effective. Most of these methods that we talked about are very effective in preventing pregnancy, but there is no method of family planning which is 100% effective. So if you start experiencing symptoms of pregnancy, you want to quickly go to your doctor and or your nurse or to the clinic. They will evaluate you and tell you what is going on. That's number one. We talked about the side effects of family planning. We talked about the problems that are associated with family planning. But let me also reassure the nation and say that the advantages of family planning, they far outweigh the potential disadvantages, the potential problems of family planning. So it is very crucial when you're starting your family planning to discuss your medical conditions, to discuss your situation with your medical practitioner, with your healthcare worker, so that they will tell you in your situation this particular method is associated with higher effectiveness and also a lower risk of complications.